Welcome to Cardiac Surgery Simplified, a series where we discuss interesting cases and highlight key moments during surgical procedures. Presented by the Frankel Cardiovascular Center.
Hello. Today, we present a 62-year-old male with heart failure with reduced ejection fraction, aortic stenosis status post TAVR 2019, and 3 vessel coronary artery disease status post right coronary artery stenting in 2019. He was transferred to our institution after multiple prior hospitalizations for shortness of breath and chest pain in the setting of acute decompensated heart failure and recurrent pericardial effusion. The patient underwent aggressive medical optimization for decompensated heart failure prior to consideration for surgery. His ejection fraction was 10 to 15%, and cardiac catheterization demonstrated a wedge pressure of 41 and pulmonary artery pressure of 72/43. His STS predicted mortality risk was calculated at 31%. However, this likely underestimated his true operative risk given his significant pulmonary hypertension, right ventricular dysfunction, and the presence of a prior transcatheter aortic valve. After extensive discussion with the patient and his family, the decision was made to proceed with surgery, which included a planned TAVR Explant, coronary artery bypass grafting, and surgical aortic valve replacement, with the potential for postoperative mechanical circulatory support. For the procedure overview, the operation began with a partial pericardiectomy with removal of fibrous pericardial rind. Next, a saphenous vein graft was harvested and anastomosed to the posterior descending artery, and the left internal mammary artery was anastomosed to the left anterior descending artery. The transcatheter aortic valve was then explanted, and a bioprosthetic valve was implanted. The procedure concluded with placement of an Impella via direct aortic graft. His preoperative echo demonstrates a dilated left ventricle with severely decreased systolic function. There is also severe stenosis and leaflet restriction of the TAVR bioprosthetic valve. Prior to opening the patient's pericardium, the lima was dissected free from the chest wall and the saphenous vein graft was harvested. Initial inspection demonstrates a thickened and fibrotic pericardium adherent to the epicardial surface. This fibrotic tissue constricts the heart and impairs ventricular filling and cardiac output. This must be removed to restore cardiac compliance and to allow us to identify future targets for coronary artery bypass grafting. A bovie is used to remove residual pericardial rind and the posterior descending artery is visualized. The artery is opened with a 15 blade and the arteriotomy was extended with pot scissors. The saphenous vein graft was trimmed, spatulated, and then anastomosed using a running 7/0 Prolene suture for end-to-side anastomosis in a running fashion. The patient's obtuse marginal artery was also diseased, however, it could only be seen on ultrasound and could not be identified through the residual rind. We then moved on to the left anterior descending artery, which was identified by epicardial ultrasound. A bovie was once again used to remove residual rind and the lima was trimmed to appropriate length. The artery was opened with a 15 blade and the arteriotomy was extended with pot scissors once again. The distal lima anastomosis was done using a running 7/0 Prolene in an end-to-end fashion. Next, a transverse aortotomy was performed. Electrocautery was used to carefully mobilize the aortic root. Initial inspection of the TAVR bioprosthetic valve demonstrated a heavily calcified prosthesis. Portions of the valve were endothelialized to the aortic wall, and a freer elevator was used to carefully separate the stent frame from the aortic tissue. The stent edges were progressively crushed using coker clamps. Once the valve was fully mobilized, it was pulled out from the annulus. The native valve leaflets are also freed from the aortic wall and excised. A rondure was used to debride residual calcium from the aortic annulus. The aortic annulus, left ventricular outflow tract, and anterior leaflets of the mitral valve were then irrigated to flush out any residual debris. The valve annulus was measured and a 29mm Avulus Ultra bioprosthetic valve was selected. Non-pledgeted horizontal mattress sutures were placed circumferentially through the annulus. The prosthetic valve was then brought to the field and the sutures were passed through the valve sewing ring. The valve was then parachuted through the aortotomy and seated into the aortic annulus. The sutures were secured with a Cornett device. The heart was then de-aired and the ascending aorta was closed with a running 5/0 Prolene suture while the patient was rewarmed. We then performed the proximal anastomosis of the saphenous vein graft. The appropriate length for the graft was measured and the vein was trimmed and spatulated. The heart was drained and an aortotomy was made with an 11-blade and aortic punch. The anastomosis was performed with a running 6/0 Prolene. The patient was weaned from cardiopulmonary bypass, but his cardiac index remained low, so the decision was then made to place an Impella 5.5 for left ventricular support. A 10mm incision was made above the clavicle, and the graft was then tunneled from the mediastinum. A sheath was inserted into the graft, and a J-wire was passed through the aortic valve. The J-wire was then exchanged for a guide wire. The Impella was then inserted over the wire into the ventricle, and then the wire was removed. The positioning was confirmed by TEE and the Impella was started. His postoperative echo demonstrated improvement in left ventricular systolic function. The aortic valve is well seated with normal leaflet motion and the Impella is appropriately positioned. In summary, we present a 62-year-old male who underwent TAVR in 2019 with multivessel coronary artery disease who was hospitalized for cardiogenic shock complicated by pericarditis and underwent urgent TAVR explant, coronary artery bypass grafting, aortic valve replacement, and direct aortic Impella placement. His Impella was removed on postoperative day 2 without complication, and he underwent stenting of his obtuse marginal, left circumflex, and right coronary artery. His postoperative course was complicated by ventilator-acquired pneumonia. He was seen in our clinic at 1 month. He was seen in our clinic at 1 month post-op and was doing well. Thank you.